Well, hello, everyone, and thank you again for joining the Vision Research and Citizen Sciences session today. My name is Mabel Crescioni. I'm a Senior Engagement Officer at the Patient-Centered Outcomes Research Institute, also known as PCORI. I am going to be your moderator for today's discussion, and just to provide a audio-visual description of myself, I am a Latina woman, and I have brown hair, brown eyes, and brown skin, and I'm wearing a light peach shirt. And sometimes I'm wearing glasses, sometimes I'm not. It's out of vanity. But so for today, for our panel, we have an exciting roundtable that is going to be discussing how community-based participatory research can be used to address social determinants of health and vision and eye health disparities. And before we get into this conversation, we have a few housekeeping items. All presentation slides are going to be available on the Prevent Blindness website, and you're going to find that at preventblindness.org, 2024 Eye Summit. And the recordings will be added within a week from today. And in addition to that, speaker and moderator bios are available at the Summit Lounge. And we are going to be taking questions from the audience, and we'll try to leave time to respond to as many questions as time permits. So use the Q&A button at the bottom of your screen to submit your questions. And like I said, we will make some time at the end to make sure that we try to answer as many questions as possible. And so before we start our discussion, I just have a few slides to share with you. So it's going to be a brief presentation because, like I said, we really want to focus on being able to have a conversation. So if we can go to the next slide. So as I mentioned before, I work at PCORI, and one of the things that I thought was important to sort of frame the conversation today is to talk about the difference between patient-centeredness and patient engagement. And so when we think about these concepts, sometimes people them interchangeably, but they really are different concepts, and it's important to distinguish them. Patient-centeredness is really the extent to which the study question you are posing and the comparisons you're addressing are of pressing interest to patients, their caregivers, or other key partners. Whereas patient-centeredness is really referring to the extent to which the outcomes you're proposing are outcomes that matter to the patients, and also thinking about the study design of low burden to participants. Now, patient and stakeholder engagement is really about the partnership approach within a study that ensures that these important groups are involved beyond the role of a study participant. And we're looking for that role to help shape and inform a clinical study. It's important to understand that these concepts and the distinction of them, because sometimes people use them interchangeably and they really mean different things. Next slide. So one of the things that we hear a lot is that how do we know engagement is important, and why do we do engagement, and why is it that we are needing to be inclusive of patients? And at PCORI, we've actually analyzed our portfolio, and we require engagement in all of our funded clinical studies. And so by looking at our funded research portfolio, we have learned that engagement really impacts our funded studies in all the ways that you see on this slide. Engagement impacts the acceptability and the feasibility of the interventions, which is really especially important for research that is done in pragmatic settings. And so engagement impacts the relevance and the rigor of the studies so that the results are more trustworthy and more useful for healthcare decision-making. And I'm sharing this so you can think through how to leverage the benefits of engagement in your work. Next slide. So, oh, can you go back one? Thank you. So PCORI recently updated its engagement guidance, and some of you who may be familiar with PCORI may have heard of the engagement rubric. And so we are moving away from that engagement rubric to what we're now calling the foundational expectations for partnerships in research. And so these 6 foundational expectations translate PCORI's definition of engagement into action by focusing on what projects should do. And so what we are really trying to do with these expectations is to provide a systematic structure for thinking about engagement. And we think it's going to be helpful for our funded investigators, but we also think it's going to be helpful for the wider research community. And that's why we're sharing them broadly. This graphic shows you these 6 individual expectations, but we also try to show that they function as a collective whole. And so to us, it's very important to be thinking that projects teams should be thinking about how do they include partners and organizations and other team members who reflect the diversity of the patients and the communities affected. We're also looking for projects to think about how do they ensure that partners can contribute early and throughout the study, including planning the study, conducting and disseminating the study results. We're also wanting projects to think about how do they dedicate funds to support engagement? How do they compensate partners for their time? How do they compensate partners for their expertise and their perspectives in a timely manner and in ways that reflect their preferences, their roles, and also that do not cause any harm in the process? We're also thinking about, when building capacity to work as a team, we're thinking about how projects can identify the skills and the strengths and the barriers to engagement and provide team members information and training and support so that they can work as a team. How do we remove those power differentials that exist in blended teams so that there can be greater communication and integration? And then for meaningful inclusion of partners, we're also thinking about what do those engagement structures look like? What are the processes that are established in a study that allow for that partnership to develop and for that inclusion in the decision-making throughout all the phases of the study? And so really focusing on how can patients and other types of partners contribute to the project's goals, scope, and scale. And finally, we also are thinking about how we get teams to think about how they gather input and feedback throughout the project to identify what is working well, what could be improved, and then how do they adjust their engagement so that they can be successful and effective in their study. Next slide. So I'm going to now move on from the presentation, and I want to introduce our panelists for this session. So I am really excited to introduce Dr. Lauren Daskivich. She is Director of Ophthalmic Services and Eye Health Programs at the Los Angeles County Department of Health Services. Dr. Priscah Mujuru is a health scientist administrator in the Division of Community Health and Population Science at the National Institute on Minority Health and Health Disparities. And then finally, Dr. Kristen Nwanyanwu is an associate professor of ophthalmology and visual science at Yale University. And so I am very excited to have all of our panelists here today. Thank you, all of you, for joining. And so now I'm going to ask each of them to start off this conversation to introduce themselves and share a little bit about their work, what the work that they have done related to community-based participatory research. And I'm going to turn it over to Priscah to get us started. Thank you.
Thank you so much, Mabel. My name is Priscah Mujuru. I will describe myself as a Black woman with naturally black hair. And I wear glasses all the time and mostly at night because I can hardly see at night. I'm almost a no-go at night. And today I'm wearing a checkered shirt, which was a fashion from the 1970s. And I have a white jacket on top. I am originally from Zimbabwe, and I currently work at the NIH, which is the National Institutes of Health. And it's the largest medical research agency in funding medical research at a global level. The NIH itself has 27 institutes and centers, and a clinical center, which is the largest hospital dedicated to clinical research in the world. And they fund over 2,500 university and research institutions with extramural funds to do research in some of the things we'll talk about. And within the NIH, I am at one of the 27 institutes, which is called NIMHD in short, for National Institute on Minority Health and Health Disparities. And our mission is to address research that impacts minority populations. Thank you, Mabel.
Thank you. And now I'm going to turn it over to Kristen.
Hi, everybody. I am Kristen Nwanyanwu. I work at Yale. I'm associate professor of ophthalmology and visual science. I run the site-saving engagement and evaluation in New Haven lab, or the SCENE lab. There's some of my SCENE lab members that decided they wanted to come. And our work uses a multi-method approach to decrease preventable blindness from diabetic retinopathy that involves community engagement, quantitative work, and qualitative work. I am a Black lady with a short tapered afro with like highlights on the top. I have pink headphones and I have this orange red lipstick that makes me make model faces in the bathroom when nobody else is there. So I'm so stoked to be here. I can't believe 100 people signed up to come and hear us talk about something so important. And I can't wait to get into the convo. It's going to be awesome.
Thank you. Lauren?
Sorry, having a little trouble with my mute button. Hi, I'm Lauren Daskivich. I am a woman in my 40s with olive skin, brown eyes, and dark brown hair, somewhat streaked with gray, proudly. It's a bit longer than chin length. My pronouns are she and her, and I'm wearing a blue shirt, sitting in front of a blue background with the LA County Department of Health Services logo on it. As that's who I work for. I am an ophthalmologist, and in my current role, I serve as the Director of Ophthalmic Services and Eye Health Programs for the Los Angeles County Department of Health Services, which is the second largest municipal eye care system in the US and the largest safety net provider in Los Angeles. So I oversee eye care for the system. So I often represent the safety net community in the research that I do. I'm in the somewhat unique position of being on both the academic side as well as representing the community partner of LA County and our patient population, which is predominantly low income, immigrant, and underserved. And my work focuses in implementation science mainly, which is studying the interventions that we do in LA County Department of Health Services to improve care for our vulnerable safety net population, and also evaluating the impact of those interventions on eye health outcomes and access to care metrics. And I'm really excited to be here today with these other fantastic panel members. I can't wait to learn from them as well.
Thank you, Lauren. So I'm going to get started with our first question to guide this conversation. So earlier, I shared a brief description of how PCORI approaches engagement with patients and other partners in research, particularly in comparative effectiveness research. But there are other approaches to engaging patients and other partners. And so I'm going to ask Priscah if she can get us started in this conversation, talking about how are your approaches to engaging patients and other partners similar or different to what I described earlier?
Yeah, thank you for that question. As I mentioned, I am at the NIMHD, and I'll continue to call it NIMHD instead of the full mouthful name of it. So at NIMHD, we envision an America in which all populations will have an equal opportunity to live long, healthy, and productive lives. And our mission is to lead scientific research to improve health and eliminate health disparities. And you can say, how do you eliminate health disparities? It's really hard to do, but at least we can reduce it. And we know that many, almost all of us are exposed to social determinants of health, but they do impact the minority populations much more than many other people in the populations, especially here in the US. So the people we serve include American Indian or Alaska Natives, the Asian, Black, or African American, Native Hawaiian, or other Pacific Highlanders, and other underserved populations who may be white and in rural areas, sexual gender minorities, and also we've been charged to address people with disabilities, and that includes vision impairments, anything to do with vision that is under disability. So in terms of engagement of patients, we expect our grantees that we fund to engage with the communities. So we support research in minority health and health disparities. We support their research to understand the causes of health disparities that may come from social determinants of health. We support training of diverse scientific workforce so that as they grow up in their work, they can start to understand what engagement of patients means. And then we want the funded people to translate, disseminate research, and foster collaboration. So to better serve these populations, our researchers are encouraged to implement community-based participatory research in their projects. And these approaches should be long-lasting, engage patients and community partners and all other federal agencies. And I'll be happy to answer more questions to that.
Thank you, Priscah. So now I'm going to turn it over to Kristen and Lauren, and I'm going to ask a different question. So part of what PCORI's foundational expectations that I just referred to earlier talk about is diversity and representation. And so for our audience, I think it would be interesting to hear what you have made to include a diverse range of partners and organizations, including those whose perspectives might have been historically excluded from research in your work. And so if you can share some examples of efforts that you have made to be inclusive. You can start with Kristen.
Okay. Sure. So the work that I do is in diabetic retinopathy. And if you look at the epidemiologic data, we know that Black individuals, brown individuals, low income individuals are diagnosed later, treated less often, and go blind more than all of the other populations. And so when we're talking about sight threatening and blindness in diabetic retinopathy, who we are talking about are those that have been marginalized historically because of the way our system is designed. And so to me, as I focus on trying to prevent blindness, for me, that is where we begin. So our partnerships include that. So I sit in New Haven. New Haven is really Black and brown and multicultural. So it's about 30% Black, 30% brown, Latin, and then a little bit of everything else, in a sanctuary city. And so asking the questions of how to deliver equitable care, how to decrease preventable blindness and diabetic retinopathy here is perfect because we have to be able to engage community members. So we partner with a lot of folks. So we get advice from a body, a community academic partnership that's over 20 years old, which is a steering committee. And so when I started this work, because I'm not from New Haven, I went and I asked them, I got an introduction from my mentor, and I went and I asked them, I said, hey, here are the questions I'm interested in. You know, what do you recommend? And so kind of that is the start, is hearing, you know, how we can get better. I think a lot of times what I will say is I think that the answers to what we do aren't at Yale. I think they're in New Haven. And so what does it look like to be able to have the appropriate cultural humility to be able to start with asking? So we do that. We have an advisory board for our lab. We also partner with Project Access New Haven, which is a care coordination patient navigation organization that is community members that know the answers that community members need and can navigate them through the complex healthcare system. I don't know who else has problems navigating the healthcare system, and I'm a whole doctor. So trying to figure that out for people that may be marginalized or more vulnerable. Also, we've partnered with churches. We are developing, co-designing a digital application with Dr. McCall's lab, which is a chill lab. And we partnered with the church in a historically Black neighborhood in New Haven to do so. And so Reverend Guilford is actually now the pastor of that church. We just had a meeting with him and our advisory board to say, okay, we did our focus groups at the community center across from the church, digested those data, and then returned that information and said, hey, look, here's where we think we're going. And for us, we can't deliver appropriate solutions unless we're able to hear. So a lot of people in my lab will tell you we are constantly thinking about what we heard and then how are we reacting to what we heard. And I think to me, that engagement is a beautiful, beautiful starting place that is oftentimes overlooked. I would not say that the work that I'm doing in my particular lab is like classic CBPR because, we are designing together. But I would say that there is definitely a participatory science component that is imperative to be able to design new systems to be able to address problems that have been evident since we could do the epidemiologic studies on diabetic retinopathy, which is over 40 years.
Thank you, Kristen, for that example. Lauren, anything you want to add?
Sure. I mean, I love listening to Kristen and all the work that she's doing and all the people that she's engaging, because like we meet a lot of these same challenges here in LA County, similar, underserved and patient population representation, though here in LA, we are heavily, Latin. And so, our patient population is majority Spanish speaking, although, we touch on minorities kind of all across the board in all sorts of different languages. Every time I look at the amount of different types of languages we provide our patient care visits in, I'm always amazed. And so one of the important things for us in our research partnerships here in LA County is that we have a lot of great academic partners that we can work with. Some of them here, USC, we have Charles Drew, University of Medicine and Science, and UCLA. And so it's been important for me to involve our academic partners and and be able to utilize their strengths and their infrastructure to bring that to bear for our patient populations, where we as the healthcare provider don't often have a lot of that infrastructure built already to do research, but they do. And so being able to utilize that while at the same time also working with companies that are, for me, my work is somewhat in healthcare delivery and eye care delivery for the safety net, and a lot in telemedicine, teleophthalmology, teleretinal screening for diabetic retinopathy, where Kristen and I have overlapped. And in a lot of that work, there's a big boom right now with AI and a lot of companies that are interested in this and interested in building out, in developing all sorts of things around AI and healthcare improvement and eye care improvement, and models and, all the data from patient populations like ours. So it's been important for me to participate in that so that I can ensure the representation of our vulnerable populations in this research. But on our end, it's very important that we are acting as advocates for our patients, so that in that way we're mandating good stewardship of our patients' data. And also at the same time, though, we're ensuring that they're going to be able to benefit from the work that's being done by our academic partners, by these companies that we're working with, and that those products that are being developed can be brought back to serve our patients. And part of the way that we do this is through careful project design, and that involves our county leadership, as well as the frontline MDs that are delivering the care, and our patients. So each of our facilities has a patient advisory council, and that is, those are implemented to help with advise on aspects of patient care and patient care delivery, but we're also able to utilize these groups to inform our research projects, which is incredibly valuable, and helps bring the patient voice into our research. And so again, I'm sort of sitting on both sides as both the healthcare deliverer and as part of the research team. But when we can work in this way with all these groups, we're ensuring that we're balanced meeting each group's needs to make this a better outcome for the whole, and in the end, to benefit our patients, which is the reason that we're in it.
Thank you, Lauren. So one of the other expectations talked about early and ongoing engagement, and in part doing that kind of early and ongoing engagement with communities to be able to conduct research. In that relationship building, there's a need to build trust. And so a lot of these relationships that we create to be able to then be able to engage are really built on that foundation of trust. And so I am curious if you can talk about what are some of your experiences in creating that trust and being able to build those relationships. And so also thinking about what roles do the social determinants of health really play in helping us develop community engagement and engagement in research. And so I'm going to get started here on this one with Priscah. So I'm going to turn it over to you to get us started on this conversation.
I guess I should not mute, right? Because then I can't find my mouse. So let me answer this question another way, and that is we are all exposed to social determinants of health. But to understand this, we have to understand what is the outcome of social determinants of health, and that is health disparities, which is a health difference that adversely affects disadvantaged populations. So if they are exposed to social determinants of health, such as environmental exposures, transportation, nutrition, which is something we saw during the COVID-19, or lack of access to health, they react differently if they're experiencing any lack of these issues, or they are reacting to them differently. In the disadvantaged population, the social determinants of health can lead to health issues such as higher incidence of prevalence, either onset or chronic diseases, higher prevalence of risk factors, higher rates of symptoms, reduced health-related quality of life, and premature and excessive mortality from disease and greater disease burden. So given all these issues of the outcomes of health, our researchers are encouraged to meet people where they are, and that is in the communities. People do not live in hospitals. People do not live in other cares. They are in their communities. So this is where they should have meaningful community partnerships and engagement. And to build a relationship means to build trust that is long-lasting. And at NIMHD, we have a framework that serves as an excellent guide to building a long-lasting relationship with the communities. Because as you know, NIH, NIMHD, we are a funding institution. We do not go out in the communities, but our researchers do. So we are there to guide them with different frameworks. And our most important framework is the NIMHD research framework. It's been published in the American Journal of Public Health, and I can share that in the chat in a little bit. It shows the researcher the levels of influence that they can meet the people in the communities at the individual, at the interpersonal level, at the community level, and at the societal level. And then also at the same time, addressing some domains of influence that can be biological, behavioral, physical built environment, social cultural environment, and healthcare systems. So all these are good ways of engaging the community. And we do encourage our funded or our applicants to address this even before we see their application and even after they are funded. We have to follow them to make sure that the engagement that they are proposing, they are being carried out. So yeah, thank you.
Thank you, Priscah. So I'm going to turn it over to Kristen now.
Thank you. Yeah, I think it's really challenging, right? Especially in the context. So, Yale just put out this 554-page volume on Yale's history with slavery. I haven't read it yet, but I think that context is really important, right? So Yale hasn't always been the best neighbor in New Haven. So when we are going to try to build community and do research, that context is important, right? So all of the ideas that community members have about institutions, we're not out of nowhere. They're right, those are valid ideas about how we feel about their health and how we are ushering them. And so it does take showing up in a particular way to be able to build that kind of trust. And it takes a really long time. I'm fortunate to have this, partnership, the steering committee that has been here for a really long time that I can tap into and say, hey, look, sign me up. But a lot of places don't have that kind of legacy. And so what does it look like when you're trying to show up and build that? And I think it's the very basics of kind of any relationship. And I just have a couple of examples for entities where community members actually lead the projects. And I think that might be a nice example. So at Yale, we do the Community Health Equity Accelerator, and a group of Guiding Coalition community members decides what the diagnosis, what the topic is going to be. And then they curate exactly what we're going to study. But Yale Power says, okay, here are the metrics, here's the background, here are these other issues. And then, but the community members decide what they think is most important. And then we power that with a funds first perspective, meaning that we give them the money up front. When I wrote my K award, my community partner had to wait 3 years until they got any of that money, which is like Yale time, but that's not community partner time, right? And so trying to figure out how to manage those relationships and to show up well is really important. I will also say that, my dear friend who couldn't be on this call today, Dr. Angie Elam, talks about how she was doing her combat intervention, which is starting. It's but at first she thought it was going to be an intervention that was remote. And then she listened to her community members and they said, that sounds great, but we want it here in the church. And she had to pivot her work because that's what they asked for. And I think the other side of that is that when you are listening, you have to be ready to move. So you have to be ready to pivot. You have to be able to show up and hear what the community says. And I think the other side of that is also when you have a relationship with one community, you have a relationship with one community. And so you have to be willing to redo that over and over again and continue to show up in the way that is how you would want somebody to show up for you. And the last thing I'll say is I think what is challenging for me oftentimes is the research infrastructure, is the small p of trying to deliver to community members for infrastructures that just weren't designed for them, right? So how do we pay community members in a way that makes sense for them? How do we support them? How do we honor their lived experience in a way that numerically makes sense, right? Make the coins make sense. I was like asking myself recently, right? If you can't get trust, can we start with cash, right? So I think what are the things that we need and how can we deliver appropriately are really, really important pieces of how we show up and engage.
Thank you, Kristen. That was a great example. Lauren?
Yeah, I mean, everything that's been said is so spot on. And really, I can just second that. I mean, I would say listening is the thing that comes up the biggest for me, because again, we're sort of in this interesting, or at least I am in this interesting position of straddling, right, the multiple worlds, because we are a community partner in the sense, but then we're also beholden to our patients and listening to them. And then trying to get our partners, our academic partners, or our research partners, the companies that we're working with, whoever it is on the other end, to listen to us about listening to them. And so it's really, the communication is so critical. It's critical with all folks involved, like those on the research arm, and then again, bringing it all back to the patients and, the people that you're actually trying to serve, to intervene and to help. And so, I think that, and that whole, the point that Kristen made about the ability, to pivot and the ability to try to make sense of all of these different things and what's important to all the different groups, trying to help that make sense to everyone, right? Like the patient's like, but the point about the money, the point about the incentives, the point about, well, wait, why do I have to come back within a 2-week window? Because, I have all of these responsibilities, that is so difficult to do, where you're talking to your research partner that's like, yeah, but the grant, the proposal or the grant proposal has put these strictures on us, right? They've put these time constraints on us, so we have to do it. But what is that like in real world implementation, and trying to explain to this patient why you're sitting there saying, well, I'm doing this for your benefit. And it's like, really? Why? How is this helping me? And really helping them understand, though, especially for us as a safety net provider, of, well, trying to explain how in the end, this is something that is created for the patient and to help the patient and to listen to the patient, but also to balance that with constraints of funding and constraints of other things that we're not all our own masters in this. And with research, we are often beholden to a funding organization or to the other partner that we're working with on the other end, and trying to help meet everyone's needs. But then, again, remembering kind of the ultimate goal in this is really about the patients. But the communication, I think, is really critical, because you still don't take away the need to have to jump through certain hoops. Those hoops are still there. As much as we may say, it's all in an ideal world, right? We could bring it back and make it just about what the patients need and pivot in the ways that they need us to. We can't always. So then the communication back of why we're doing it this way, because trust, again, is that backbone. And so they have to trust us to understand why sometimes we can't give in all the ways that we need to, or all the ways they may like us to. And so there's a balance between what we're able to do, or what we want to do. But in the end, that we're coming from, the place of really trying to better the environment and better the care for all.
Thank you, Lauren. Kristen, you got us started on the path of talking a little bit about how we compensate for engagement. And, as I talked about earlier, dedicating funds not only to compensate our partners, but also to have the structure to be able to engage and to be able to support the activities, and to be able to have interpreters, training, or other technology that creates an environment for those that need additional support to be able to engage, to have those tools and resources available. Can you talk a little bit about, I think you kind of started down that path, can you talk a little bit about what your community projects and have done to be able to support engagement from a budget perspective?
Yeah, so we, recently wrote this grant. We are developing a digital health tool called a Scene tool, right? So novel, to try to engage people at risk for diabetic retinopathy, and it's a co-designed tool. So when we wrote that, we wrote in resources for an advisory board. We also wrote in resources for people to participate in the focus group, and kind of focusing on that. But I think conceptualizing that, I think, is challenging, especially with restrictions on resources. But I will say, I had a friend of mine who asked me, he said, "Oh my gosh, how will you get the advisory board to attend the meetings?" And I just turned to her and I said, "You pay them." And I think some people aren't even there yet, right? Where you realize people will volunteer their time because we have a lot of good humans that would like to advance science. And we should compensate people for their work and for their lived experience, right? So I'm a vitreoretinal surgeon. People ask me questions on the things that I know about, and there is a rate, right, that they will offer me to be able to do that. There is also a rate for our community members that are living through the experiences that I don't understand, because I'm not living through those experiences, and I should compensate them for their ideas. I should compensate them for how they know how things will move. So we finished the focus groups and done the affinity mapping for this project. And what keeps coming out is, this concept that Dr. Tarika McCall calls it life flow. And it's really about, a lot of our community members, they understand diabetes and they understand what they're supposed to do, but it's really challenging to figure out how to fit it into their life flow. And so I can't conceptualize that unless I can hear them, and unless I can hear their journey, unless I can hear what is possible and what is necessary to allow them to move through their particular world with diabetes. And I can't make a good product, right, if I can't do that. And so I think for me, it's really, really imperative to figure out how I get the appropriate resources to here. So when I am building a grant, when I build a budget, I build that part first, so that I can make sure that I have the resources for them, and the rest of it has to come from there. I have another example. Erica Spatz has a beautiful PCORI-funded project on hypertension that's in New Haven, and I happen to be in one of the community organizations that she is working with, and she is giving resources to a community organization in a lump sum, so that they can help to further the research and get that engagement. So I think that our concept of how we compensate community organizations, community members, participants, really, really has to be broadened to be able to build infrastructure and to be able to build solutions that really, really hit the mark in ways that we haven't seen before. And I think it will require cash.
Thank you. Lauren, did you want to add anything to this question?
I mean, I think that's the most important point is that we're making sure that we are making it feasible for our patients and for that community to participate in the work, and just expecting it, right? Expecting, even as us, as a healthcare provider, that, well, this is the expectation that we have in order to be able to provide that care. We still, especially when we're involving kind of the research in the process, that we have to build in that incentive base for them to be able to do so, because of all the social determinants of health they're facing, to enable them to come in to even get the basic care essentials. It's so much. And so when we're asking anything on top of that, we have to be aware of what we're asking. It's just, to me, it's constant awareness of what the community is coming from, what the patient is coming from, what their needs are, and how we can meet those and meet, of course, the others as well, right? Meet the research needs of the researcher, the needs of the funding organization, but not just with that expectation that this is just sort of this, moldable piece that we can build in as we need it to. It's one of the, like Kristen said, the first thing to be addressed is like, what are the community needs in this? What are the patient's needs in this? And bring it back to like the root of what we're really trying to do here and who we're really trying to serve.
And I'll also add, I think there's an important conversation that's happening on a national level with regards to clinical trials as well, and trying to figure out how to, in light of FDORA and the new legislation that's coming out about from the FDA about diversifying clinical trials. And I think all these pieces are really imperative in that, right? From kind of a history and legacy of trustworthiness to kind of how we can manage getting folks that are historically excluded the opportunity to be able to participate in some of this, cutting edge science. And those pieces are really, really going to be important going forward to figure out what that actually looks like.
Thank you. One of the things that we observe in our work is also the importance of not causing harm. There's a lot of, benefits that people receive, and a lot of times compensation can affect those thresholds. And so it's important to think about what harm, unintentional harm you could be causing.
Absolutely.
Thank you, both of you, for that response. So we have a couple minutes left of the session, and so I want to at least ask one question that came in through the Q&A. And the question says, how can we make all healthcare providers to engage in better ways with the visually impaired and blind? It seems like the entire healthcare system is not adequately working with the blind, or is not adequate for the blind impaired, from the small instructions on drugs at the pharmacy to the small font on paperwork at the doctor's offices. So any thoughts? We can get started with either Priscah or Kristen. Lauren?
I would agree. I mean, I think it's terrible. I remember when I tried to have them change my business card, because I'm a retina surgeon, let's be honest, right? A lot of my patients are visually impaired. And I just wanted them to be able to put a bigger font or a bigger number or something on the back, and it kind of flipped the whole system. I also feel like that with the consent process, right? Although I do say, I ask some of my visually impaired patients if they want me to read it to them, and they invariably say no, they don't want me to read this kind of Yale stock consent to them. But I do think that we need to do a much, much better job at figuring out how to be more inclusive by engaging our visually impaired community, and what really would help, right? What would make it easier to be able to engage in that way. I think that is really important. I think we're horrible.
Yeah, I agree. And I mean, one of the things in the definition of safety net providers is that you provide wraparound services. And so, more than just medical care, right? Because a patient, our patients are looking to us for more than just that. And that's what helps us ensure that we're providing the best medical care we can, and for addressing all the needs. And so, yes, we think about things like language services, right? And social work and all of those, but the visually impaired is something that tends to not be the top of everyone's mind in that. And I think one of the ways that, because I think the county itself, in LA, we've struggled with being able to provide that within. So having other partners like the Braille Institute and others to help us in that. And then having those top of mind when we're developing other interventions. Like one of the things we've worked on is digital health navigators to help patients with all these things we're implementing that are for them, but like patient portals and, all this telehealth and all these things that require an internet connection and internet savvy and tech savvy and all the stuff that we're just putting on our patients, but without any help in figuring out how to make any of it work, visually impaired or non. And so incorporating, though, I think that into the work with the digital health navigators of also thinking about people that have additional challenges like visual impairment in accessing some of these, the tech or the new pieces that we're bringing into healthcare is really important. It's something we need to do better.
Thank you, Lauren. So as we get close to the end of the session, the last question that I wanted to pose to our panelists is about, okay, all of a sudden my word froze, sorry. What are your recommendations for patients or community organizations who are looking to do this kind of work or get involved in engagement or community-based participatory research? What is, from your experiences, what can you recommend to patients or community organizations? And we can get started with you, Kristen.
I would say just get started. It is hard when you see all of the social needs of your individual patients and you see, the barriers, but starting with one connection. I was just giving grand rounds in Ohio and Dr. Orr was asking, how do we get started? And I was like, just pick one, right? If you're in the clinic and you have a community that is, coming in and you say, you know what, maybe there's an organization that you can go and speak to, right? Or engage with, right? Just get going, get out there. Now, you don't have to get out there a lot. It doesn't take a huge amount of effort to be in community, but I think it's just getting going and then kind of rejecting the paralysis that is like, oh my gosh, these problems are too huge, right? Like just kind of jumping and saying, hey, look, how can I be helpful? And I think that always is a beautiful start.
Thank you.
I would follow on that by saying, one of the things that I've found that my most successful projects have been ones where the strengths of the participants are complementary and the mission is aligned. And so if you're developing teams or folks to work with or work to do, you could design it with that in mind. I mean, one of the examples of something that I think has been so strong in the work that I've done has been in my partnership with Charles Drew University of Medicine and Science, bioinformatics folks there, Dr. Lola Ogunyemi, who has been a fantastic partner, and also with some computer science work at UCLA, we've been working on developing models in AI to help us determine, just based on chart and demographic data, which patients are at highest risk for diabetic retinopathy, so that we can better target our limited outreach resources in the safety net to getting those patients in, those ones that are at highest risk. And this was a need that, that my partners at Charles Drew, that Lola was very interested in and had seen, the detriment of patients going blind on her end, so felt very passionate about this. And it's something that I certainly needed on my end as the care delivery of how do I get the people in that I'm the most worried about? Who can help me figure out who those people are? And then, I have my partners on the other end saying, like, we've got the skills to help you figure out who those people are. And so it's like, great, and we'll work together on this. And the passion and the mission alignment, I think it makes it the most fulfilling work for all that are involved and really helps you maximize what you're doing and then ensure that you're bringing it to fruition in a way that really matters. It's just when you have that care and excitement about it with all the groups, and that's the mission alignment that I think can be really critical. If you find work where you've got that, then and that's the most fulfilling to do.
And I would just add that at the NIH, because we give out funds to researchers, but of late, there have been programs that are out there for people who are not in academia, people who are in the community, to apply for funding, and they have to be community members. So they can put a grant together responding to a transformative research to address health disparities. And so not everyone should be an academician. They can be just community members applying for funding so that people in the communities can do research which will directly benefit them and have input into making changes in all these health disparities, in all these community engagement. And we can learn a lot by them leading the research instead of the academician, a professor leading the research. although they can partner with them instead of the other way around.
I am going to take that from you, Priscah. Not everyone should be an academician.
Amen.
Thank you. So we are at time for today, but I want to thank our panelists and all of you for joining us today.